Hi, my name is John Absher, and I would like to provide you with an introduction to the broad field of dementia. My background in this area is that my fellowship is in behavioral neurology and dementia. I spent 2 years at UCLA doing a fellowship in this area, and I spent 7 years at the Wake Forest University, where I was involved in dementia and behavioral neurology before coming to Greenville. I'm now a member of the Department of Neurology, Division of Neurology, Department of Medicine here, and a member of the GHS Neuroscience Associates Group. We will discuss several areas related to dementia today, including definitions, importance in epidemiology, diagnostic classification, evaluation and management, and your roles in dementia and future direction. First, we'll define several terms, including minor cognitive impairment, what is a dementia syndrome, and different types of dementia syndrome, such as rapidly progressive dementia, early and late onset, sporadic and familial forms, and mixed. First, mild cognitive impairment, also now called in the new nomenclature minor neurocognitive disorder. To qualify for this, you have to rule out delirium or acute confusional state, and it can't be related to another psychiatric disorder such as depression or anxiety disorder, panic disorder, etc. Intoxication from drugs or substances, that sort of thing. It may not be sufficient to interfere with functional independence or functional status. If it does, then you probably have enough of a problem for this to be labeled as a major neurocognitive disorder, as we'll see on the next slide. It may be an amnestic MCI or a mixed MCI, and in fact, MCI may be major neurocognitive disorder is the new term for what we used to call dementia or the dementia syndrome. As a syndrome, it is not a specific diagnosis. This is a point of frequent confusion. Dementia is a syndrome, much like pain. It can be due to any number of different causes, and one of the first priorities is to identify an underlying cause. It's defined as an acquired disorder of memory or other cognitive domains that is not explained by delirium or psychiatric disorders, and it is sufficient to interfere with independence. Rapidly progressive dementia may develop over weeks to months or rarely over days. It can sometimes be fatal and may be fatal quickly, requires a workup rather rapidly, and there is a broad differential diagnosis. The DDD vitamins is a mnemonic that may be used as described here. We're going to come back to this, so I won't belabor these points, but you have been exposed to this type of mnemonic in the past, I'm sure, to classify the etiology of various disorders in other specialties. We'll talk about some of them in this talk. I will probably create a second lecture to go into the details of the differential diagnosis in more detail. Presenile dementia is onset before age 60. Some people say 65. Also used to be called early onset. And then after that age, we call it late onset, which may sometimes be confused with normal aging. Sporadic dementia is not known to relate to a specific cause, particularly in inherited or genetic disorders, which may be dominant, recessive, or non-Mendelian in their inheritance, such as mitochondrial disorders or even epigenetic. Environmental factors may sometimes masquerade as genetic disorders, for example, if toxins or radiation exposure or other factors in the environment. Even infections can be transmitted in what may look to be a familial pattern, such as with syphilis, for example. Mixed or variant forms of dementia are very common. For example, vascular and Alzheimer's disease, probably the most common mixed dementia that you'll see. You may see frontal presentations of Alzheimer's disease in association with vascular disease. You may have a variety of other dementia syndromes that can coexist with other types of pathology. In fact, there's almost no pure cases of Alzheimer's disease or other types of dementia, as we'll see in the next slide. This is a pathologic study looking at the autopsy cases in patients who were defined clinically to be pure and based on pathologic specimens. And you can see there's very few that were actually proven to be pure when they finally came to autopsy. There's quite a bit of mix. Alzheimer's disease is AD, VAD is vascular dementia, PD is Parkinson's disease, DLB is diffuse Lewy body disease, which you can see is LB as well. PSP is progressive supranuclear palsy, and FTLD is frontotemporal dementia syndrome. Next, we move on to a discussion of the importance and epidemiology of dementia. This is a broad topic, and I'll break it down into these areas. There is a great deal of work ongoing now because of the great importance of dementia. It is an important area worldwide and increasing in importance because of in terms of the cause of death in the United States, I believe it's number 6. I meant to go in and verify this, so don't quote me on this, but it's in the top 5 or 6 causes of death in the United States. It sometimes varies between 4, 5, and 6 over the years, but I believe it may be number 6 currently. I will try and verify that before our face-to-face encounter. Men tend to die younger, and therefore by the time dementia develops, women are 3 times more likely to have dementia than men. Most people end up dying without a will, and blacks and non-whites have a higher mortality rate from dementia. So it tends to be disproportionately lethal for minority groups. The morbidity can affect several different domains: cognition, behavior, function, and a type of function which I have split out called social and occupational function, with special importance, which we'll discuss. And the costs are quite staggering. One of the last years for which I had figures estimated approximately 175 plus almost $200 billion per year of direct and indirect costs in the United States alone, and approximately $750 billion worldwide annually in direct and indirect costs to care for patients with dementia syndromes. Those numbers are going up. So this is truly a break-the-bank kind of epidemiologic crisis that we're seeing worldwide. Intangible costs are almost never measured because they're just too difficult to measure. The cultural loss might include such things as the inability for someone with dementia to carry on with their culturally important work and contribute in the fashion to which they've been accustomed to the cultural enrichment of their society, and the same goes for intellectual contributions. Emotional intangible losses can affect their immediate family, and if they happen to be someone famous, may also have a wider impact, such as with Robin Williams, for example. So, importance in epidemiology, as I mentioned, is related to the aging of the population, which you've all heard about. Some countries seem to be aging more rapidly than others. Italy, Japan, United States, for example. Some countries, like third world countries, for example, have a younger population. There's more of a growth rate, and the birth rate is higher. So therefore, the demographic trend has not yet shifted to the right in terms of the old population. So those trends haven't hit many of those third world countries quite in the same manner. Migration patterns may affect resource utilization within various countries, as we're seeing in Europe right now. So at the same time, you have some of the countries struggling to meet the needs of elderly. You may also have resource scarcity affected by other strains on their systems, such as migration patterns. Not only that, we already have a situation where the middle-aged individuals are called the sandwich generation, where they have youngsters to take care of as well as their parents. They're the so-called sandwich generation because of they're sandwiched in the middle of the young and the old, for which they have care responsibilities financially, emotionally, etc. Now, the ethics of dementia is a complex issue, and we could literally spend an hour on this. There's been a great deal of work looking at end-of-life care and medical futility policies. It's been very difficult to get medical futility policies implemented in a widespread fashion. Consequently, this is largely left to individuals in South Carolina and in many other states. I'd hesitate to say most states. What this does is creates further problems, and to some extent, with resource scarcity and allocation. Just as an example, last week I had a 98-year-old woman who came in, and by the time a decision was made to give her TPA, we ultimately realized that she was demented and would not have wanted to live with global aphasia and right hemiplegia, and subsequently she was put in hospice care, and end-of-life decisions were made. But at the time, I think there were tremendous efforts spent on her acute care. This type of activity happens day in and day out, where resources are allocated for the care of elderly, demented individuals, and sometimes the results of that effort leave or lend a little additional quality of life in those last 6 months on average for the amount of money that's spent. About approximately 80% of the Medicare budget is supposedly spent during those last 6 months of life on average. So this is a situation that will need to be addressed. It's an ethical challenge that needs to be addressed at this point, and is going to become a more prominent issue going forward as we face increasing problems with healthcare in the future. We also have other ethical challenges, such as increasing knowledge about the genetics of dementia syndromes, and family members who demand to know their risks, insurance companies that demand to know whether the people that they cover with health insurance are at risk, etc. So there's a large field related to genetic knowledge and testing, and whether or not these individuals should be told about their genetic risk, because in many cases we don't know how likely they are to come down with dementia, even if they carry some of the risk genes. There's also additional ethical issues related to caring for the elderly, taking away their autonomy, in which kinds of situations it's necessary to take away autonomy, whether it's proper to assist them with suicide, for example. There's many situations like this which we have not fully resolved the ethical quandaries that we face. There's many research challenges as well, such as defining the mechanisms for specific dementia types, including prevention and cure, defining disease classification, both on the etiologic level and genetic level, and optimizing the quality and outcomes for dementia care. And research ethics is a separate issue as well. How do you obtain informed consent for a research trial? For example, when someone lacks sufficient cognitive function to provide decisional authority, is it proper to obtain consent from someone else in that setting for research purposes? It may be perfectly reasonable to do that for an effective treatment without their ability to consent, such as with TPA when a patient is aphasic, or the clotbuster drug used for stroke, for example. But what about using an experimental therapy that may do them harm, or that may have implications on their offspring, because you may find out about genetic risk that can have implications throughout the family. So to simplify thinking about the dementia syndromes, the etiologic classification scheme is important, and this is the DDD vitamins classification scheme again, and I add the GPT at the end, genetic, psychiatric, traumatic. So this, you can read this just as well as I can. I'm going to just go through during this talk and just illustrate a few of the common exemplars from these categories. Developmental cause of dementia doesn't seem particularly common, but I've seen a few cases, for example, of patients with congenital aqueductal stenosis who would develop normal pressure hydrocephalus, what appeared to be normal pressure hydrocephalus in late life, and it turns out that it was probably an obstructive type of hydrocephalus because of the aqueductal stenosis, which is a developmental type of phenomenon, we believe. Demyelinating disorder, multiple sclerosis, for example, can cause a dementia syndrome, as can other demyelinating disorders, such as adrenoleukodystrophy or metachromatic leukodystrophy and others. Degenerative diseases, there are many of those, such as Alzheimer's disease, Parkinson's disease, Huntington's disease, motor neuron disease, etc. Vascular disease, there are many dozens of causes of stroke, and anything that can cause stroke can cause a vascular dementia. Infectious diseases can cause dementia, such as HIV/AIDS, for example. Syphilitic dementia. Syphilis used to be the #1 cause of vascular dementia many years ago. Toxic and metabolic factors can lead to a dementia syndrome. For example, alcohol abuse. That's probably the #1 cause, but of course there's also other types of toxins that can lead to dementia syndrome, such as the heavy metal toxicity, the mercury, etc., lead toxicity, and that sort of thing. Autoimmune diseases, lupus would be a good example there, and there's also some of the rapidly progressive dementia syndromes, like the NMDA receptor encephalitis syndromes, which fall into this category. They may be paraneoplastic or autoimmune disorders that cause rapidly progressive dementias. Metastatic disease, either tumors within the brain that can cause dementia syndromes, or paraneoplastic syndromes themselves. Iatrogenic causes of dementia. It takes a little creativity to come up with this one, but you can imagine if you had a patient who suffered from an arrest or a hypoxic ischemic insult in the hospital, and then ended up with a global anoxic insult that rendered them incapacitated from a hypoxic ischemic encephalopathy, that would technically fall in the category of a vascular type dementia from a global ischemic insult. The neurodegenerative is probably within the broad category of a degenerative illness. There's sort of a duplication there. Systemic illnesses, you have someone with a Systemic illness, most of the time you can reclassify these as systemic infectious, systemic autoimmune, systemic metabolic or toxic, etc. And then genetic disorder. There are many genetic disorders that are related to dementia, whether it's Huntington's disease would be a classic one. Wilson's disease would be another one that can cause an early onset dementia syndrome. You have familial Alzheimer's disease with presenilin 1 or presenilin 2 mutation, or amyloid precursor protein mutation, etc. Down syndrome would be another example. Psychiatric causes of dementia. There is a thing called pseudo-dementia, where people think they have dementia, but they really don't. And then there's also dementia syndrome of depression, which would fall into this category, which is an actual dementia. And then you can also have traumatic causes. And to some extent, the normal pressure hydrocephalus can go in this category, although it may go into one of the other categories above as listed, as we discussed. But traumatic dementias may also be dementia pugilistica, for example, the chronic traumatic encephalopathy syndrome, where repeated blows to the head cause damage and degeneration, and oftentimes associated with plaque and tangle disease that may have the appearance of Alzheimer's disease or a similar pathology. So challenges to classification are that the clinical syndromes are often imprecise and they overlap, and there are mixed syndromes, as we've discussed, and so we're not very good at clinically distinguishing these groups with a great deal of precision. We have to try. We need to be as precise as we can, but there is a great deal of overlap and blurring of boundaries between one clinical syndrome and the other. For example, I saw someone just the other day, and the differential diagnosis included Lewy body disease, Parkinson's disease, and normal pressure hydrocephalus, because all three of those diagnoses can lead to short steps and shuffling gait and instability. The patient also had a tremor, and I would note that vascular disease of the brain can also cause a gait abnormality that looks very similar to this, called the march à petit pas. So you can have 4 different things that can look like a Parkinsonian gait. So there's a great deal of difficulty sometimes clinically distinguishing these individuals. Genetic and sporadic diseases can overlap. You can have, for example, familial Alzheimer's disease, and then you can have a genetic Alzheimer's disease, and you can't really tell them apart. They can look exactly the same. Many genetic disorders have a sporadic component and vice versa. Some people would say all of them do. And all of the sporadic cases have a genetic contribution in at least some of those cases. So the phenotype alone is not enough. There's a great deal of complexity and cost associated with knowing which tests to do, and sometimes there's a degree of diagnostic nihilism involved. Why should we bother testing? Because it's a degenerative disorder and incurable, and why bother going through the expense of testing if we can't fix it anyway, and our therapeutic options are limited? And I think that this is something we'll have to discuss during later slides. But I think that those are some of the challenges that we face in dealing with the classification of dementia syndromes. There has been limited testing because of this nihilism that we've been facing over the years. The rapid evolution of the field makes it even worse, because as the number of tests and the different types of dementias keep expanding, then the gap between the amount of testing that's done and the amount of testing that's needed seems to be growing. So we're facing a wider and wider gap diagnostically and a wider gap in terms of the types of treatments that are available that are targeted specifically to the etiologic process for which our therapy should be directed. All right, so the key dementia subtypes to know are listed here. Of course, Alzheimer's and familial Alzheimer's, frontotemporal dementia, including Pick's disease, vascular dementia, NPH, Parkinson's, and the Parkinson's lookalikes like Lewy body disease and corticobasal degeneration, depression-related dementia, Huntington's, HIV/AIDS dementia complex, post-traumatic dementia, and then the sporadic and variant CJ disease. Lecture or during a separate hour that I audio tape. Now, the diagnostic evaluation, of course, begins with a history, your general exam, neurological exam, some form of cognitive examination, and a neurobehavioral exam and or cognitive assessment and blood work. Blood work includes basic things like oxygen, electrolytes, and urinalysis, and looking for toxic exposures and various things like B12 and folic acid and thyroid functions and immune disorders. I usually do a basic screen like ANA and SED rate, and in some people I do an HIV. HIV is one of those things that is fairly common, shouldn't be overlooked. The neurobehavioral examination, you may have learned about this along the way in psychiatry. These are some of the characteristics of the neurobehavioral examination, and that it is probably too much to get into the details here, but you want to touch on the various domains of cognition, including attention, language, memory, visuospatial, and executive domains. The psychiatric interview should also be addressed, particularly looking at behavioral abnormalities such as psychomotor agitation and picking or motor restlessness and those sorts of things, looking at for mood and affect disturbance, the thought process and content disturbances such as psychosis and hallucinations, etc. Personality changes are important to recognize as well through history obtained from the family. Additional history that you will want to obtain would include a whole raft of additional considerations, some of which are listed here, and this more or less to get you started. Drugs, alcohol, falls, trauma, cancer, MS. REM behavior disorder is an important one. That is acting out your dreams, because that is associated with the Lewy body disease and some of the others. The movement disorders are important because that sends you in a specific diagnostic pathway, whether they've had prior images that you might be able to compare to the normal images, and whether they've had standardized cognitive assessments that you may be able to compare with the current assessment to determine how time. Additional quantitative metrics may include CSF tau and amyloid ratio, CT or MRI scans to look for all the variety of things you can see on brain imaging. Brain imaging is quite important in diagnosing and characterizing the type of dementia. And again, this is a topic a little bit beyond the what we can get into in great detail here. EEG can be helpful to rule out non-convulsive status epilepticus. Most of the time with Alzheimer's disease and other degenerative dementias, you'll see only a mild degree of slowing. If you see severe slowing, usually there's a more significant dementia or a more structurally significant process going on. Periodic discharges are often seen in some of the infectious processes like CJ disease, for example, and or some of the autoimmune or paraneoplastic syndromes, where this test can be very helpful. Management can be broken down also into these 4 domains, as I discussed previously. We're going to go through one. So for cognitive management, first thing to do is to recognize the spectrum of the types of cognitive deficits that you can see. We talked a little bit about this earlier. You can see attentional deficits. Attention deficit might be, it's not what you think of attention deficit like ADD. It may be that they can't really focus, they can't multitask anymore, they can't really concentrate, maintain the fixation, and they can't do parallel processing like they used to. It overlaps with the dysexecutive syndrome towards the bottom there. Memory deficits can be learning new things, retaining information. It can also be recalling information or recognizing things. Language skills can be disrupted, including retrieving words from memory or comprehending information. Visual and perceptual difficulties can include failure to recognize other people, inability to find their way around familiar places, and that sort of thing. Praxis means the ability to use your arms and legs for coordinated motor acts, and it involves higher level cognition to be able to carry out those coordinated acts when your body is physically capable of doing that, but your mind can't put those motor programs together in order to be able to do the maneuvers. Gnosis is knowledge of deficits, and oftentimes patients with dementia lack the awareness of the deficit. That's a type of cognitive impairment. So the interventions that are available are fairly limited. We do have some cholinesterase, acetylcholinesterase inhibitors that are available that will stimulate acetylcholine production, or actually not production, but will prevent acetylcholine breakdown in the brain and prolong the effect of it so that it will last a little longer and promote memory function in the brain. Some other types of function can be promoted as well. The NMD receptor antagonists like memantine, for example, can also be helpful for cognition and memory functioning. Some other types of neuropsychiatric symptoms may be helped as well by these types of cognitive stimulating drugs. Physical and mental stimulating activity, like exercise or brain games and socially stimulating activities. We think they're probably good for people, but the evidence is somewhat lacking that mentally stimulating activities will prevent dementia. We think that if you're going to get it, you're probably going to get it anyway, but it is helpful nonetheless, I think, to keep an active mind and an active body, and particularly physical activity seems to be a little bit more important than mentally stimulating activity. And I encourage people to do both types of activities as much as they can, even before they develop symptoms, and certainly once they develop symptoms of mild cognitive impairment. Neuromodulator therapies and experimental interventions are not yet ready for prime time. By this I mean such things as direct transcranial stimulation, and I'll talk about the next slide. When I was at a presentation recently, they were talking about using a tool called deep brain stimulator. Here you can see this dark signal is a magnetic probe inserted right along the column, the anterior fornix right here. And so what they would do is stimulate the fornix so that the memory circuit, the Papez circuit, was stimulated. And as you recall, that circuit flows up and around and into the hippocampus. And so by stimulating that memory circuit, they were able to stimulate activity within that circuit and thereby increase activity within the circuit and promote memory functioning to a mild degree in patients with Alzheimer's disease. So there is some interest in this. It hasn't gone out to experimental trials right now, but it is being looked at. Management It also needs to be directed to behavioral and neuropsychiatric diseases or aspects of the disease. Once again, recognize the spectrum of the deficits. It includes many neuropsychiatric symptoms: depression, mania, anxiety, panic, catastrophic reactions, or sudden feelings of being distraught or upset, usually provoked by a minor task failure, personality changes or personality disorders, agitation, restlessness, repetitive behaviors such as picking, pacing, wandering, repetitive verbal behaviors, those types of things, psychosis, delusions, hallucinations, sleep-wake cycle irregularities, appetite disturbances such as eating too much or not at all, and sexual disorders, masturbation or fondling others, and those sorts of things are quite common manifestations of the neuropsychiatric spectrum of disease syndromes. You can address those types of problems with a variety of medications. You can attempt to use non-drug treatments and environmental manipulation. For example, if someone is wandering, you may be able to create an environment that is more stimulating so that they have less of a tendency to want to wander away from their environment. You may end up putting barriers in place so that they're not able to get out of their immediate environment quite as easily. In some cases, a patient with dementia may be amenable to psychotherapy. I've had some patients with hypersexual behavior who to respond to psychotherapy, for example. And in some situations, you may be forced to resort to either physical or chemical restraints because you have to protect the people that are exposed to individuals and may be at risk because of these behavioral neuropsychiatric symptoms. Functional deficits are important as well. Your goal should be to first maximize cognitive and behavior control. You may be able to apply some adaptive equipment. For example, if you have a vascular dementia patient who needs a cane or a walker or an AFO device to keep their foot from dragging the ground, and that's an easy one. They may need a wheelchair or a rollator, for example, if they have such severe Parkinson's disease, dementia, or NPH that they can no longer walk safely. They may have difficulty getting on and off the commode or making it back and forth to the restroom. So you might have to implement a bedside commode, for example. Those are some examples of adaptive equipment and environmental manipulation. Reminders and prompts and memory tools may be used in order to help them deal with their functional deficits, like that involve missing appointments or forgetting important things that they need to do on a day-to-day basis. And I like to recommend people use the digital calendars like their smartphones, because they can set them to send them a text or an email, or to call them with reminders and repeat those reminders so that they will be continually reminded about the need to do something that's important. They may also require personal assistance with those functional deficits, of course, a helper or an aide to be there with them. Sometimes you even have to do that without their consent. For example, someone to do the driving or to do the banking for them. This is particularly important when they're tends to put them at risk or put other people at risk. And that leads us to the next topic, which is the social or occupational function. This is really a type of functional impairment, and the only reason for separating it out is because I think it's a type of functional deficit that tends to put other people at risk. It's the patient. The patient may be a danger, but more important in this particular category, are there other people at risk as well? And are other people going to be impacted if they make a mistake with their financial decision making or their banking matters, their business decisions or legal affairs? Are there health decisions? Are they responsible for young children, for example? And are they going to make a mistake about giving them their medicines? Are they taking care of an elderly spouse and for whom they're responsible for administering medications? Those are some of the examples that come to mind about individuals who may not be able to function on behalf of others and may get in trouble in dealing with others and you need to intervene in that regard in order for them to be safe in their dealings with other people. Same is true, of course, if they become physically or sexually aggressive. There may be many other issues that come up that you'll face in this. Now, your role in dementia care. This is a broad topic, but I think it's an important one for you to think about now. You're going to be undoubtedly exposed to individuals who have dementia syndrome, probably within your own family. And so it's a good topic for you to become familiar with. As a professional, you will undoubtedly be exposed to it many times throughout the course of your career. And depending on what specialty you're involved with, you may have a greater or lesser emphasis, and the types of involvement may be greater or lesser as well. For example, if you go into one of the primary care specialties other than pediatrics, you're most likely going to be seeing it quite a bit. If even in pediatrics, there are a variety of pediatric dementia syndromes. I've had individuals in their teens to become demented. And it's well known to occur in the pediatric age group. So very important for you to become familiar with it, no matter what your specialty turns out to be, and because it will affect you individually, it will affect you professionally, it will affect your pocketbook, it will affect our society. And not only that, dementia offers a huge variety of career options for you that span the continuum of care, from acute to long-term care environments, from surgical to medical specialties, and from clinical to research domains, everything from the bench to epidemiology types of research. So really, no matter what type of interest you have, you can find a niche within the spectrum of dementia to dig in and find an area that you can enjoy working in and make a contribution should you choose to do so. So future directions and needs in dementia. I like to think that we will come up with better tools for making a differential diagnosis and identifying the biomarkers to allow us to really pin down precise etiologic diagnosis in majority of patients. It may take many years to get us to that point, but the whole field of dementia is really barely 100 years old. The Alzheimer's famous case was 1906, and so we're really this is a very new field. Coordination of care is a great necessity. It's a multifaceted problem, requires coordination of multiple types of subspecialists, including geriatricians, psychiatrists, rehab, neuroimaging, primary care, neurologists, you name it, rehab team, the family, social resources, etc. Effective treatments are necessary for all of the spheres that we've discussed previously, including cognition, behavior/neuropsychiatric treatments, and then, of course, the functional ramifications of the disease and the societal burden. It'd be nice if we could come up with immunizations or preventative techniques, and it's going to be imperative that we address the ethical and moral quandaries posed by the challenges of dementia. Those are huge at this point, not just the financial aspects, but the decisional aspects, the autonomy, who makes the decision when someone loses their autonomy and when they don't have that autonomy. Those are all very critical issues, and they spill over into the research area as well. We need to devote a lot more research resources to this population in order to address this complex topic and address the crisis of dementia in the future. So thank you very much, and I look forward to meeting you in person, and I'm going to most likely talk about differential diagnosis of dementia in more detail in a separate talk or during our face-to-face coming up shortly. Thank you.